I'm curious if DCB is adequate, or did I need to put a stent in?
All right, guys, we have another I'm really excited to hear about this case with Arvin Narula. This is a Shockwave coronary case from our illustrious Shockwave moderator, and he's going to be fixing a Lima with some complex tips and tricks. And the last time I saw someone try to Rota a Lima, Arvin, it was Paul Tierstein at one of the Scripps live courses, and it did not end well. So I've always had a little trepidation myself on Lima intervention. So I'm excited to see this case you're sharing with us today.
Perfect. Well, thanks, Joe. Appreciate it. So here's the case here. So 76-year-old man, classic risk factors. So he had recurrent angina despite 2 antianginals. And he already did have an attempted revasc, but the problem is that 90 centimeter IM guide was not available. And this lesion was pretty distal. So we only had 100 centimeter IM guides at that time on the previous intervention. So we could only do basically like angioplasty at that time. So he just had a balloon result and nothing else at that time, just because of the length of the guide. And I think the last case was done femorally. So I'm like, I don't know if I'm the last person on earth doing left distal transradial, but
it was really hot for a while, Arvin.
Yeah, I still wear skinny jeans, and the left distal transradial is still a thing. But I like it. So the way I do it is I basically sacrifice the patient's left groin, make that unsterile, but I'm able to get access in it. And I personally think the left radial is easier to engage the Lima. I just always found that a little bit easier. So that's why when I'm doing a Lima intervention, I was like, oh, this is good guide support. It's probably the case that's worth it. So
I 100% agree. I think you're at lower likelihood of dissecting it too, just because of the way it sits.
Yep.
And if the IM doesn't sit right, you can use one of those VB guides, which is basically a pigtail that they've cut. And those are great guide support for left radial.
We don't have those.
What's up?
We don't have the VBX.
You should get it. It's a really nice kind of armamentarium. But no, I totally agree. The 90 centimeter guide's an interesting thing. I've done a number of Lima interventions with 100, but I guess if it's really distal and it's a long Lima.
It gets tight. You run out of room.
Got it.
Right? You do run out of room. So here's the case. Here's the Lima-to-LAD, and you can see distally, I mean, just distal to the graft, there's a severe stenosis. So again, that was ballooned previously, but this case was pretty challenging because it was heavily calcified as well. So
and it's actually tortuous. I think that's the other thing I think about when I look at Lima interventions is if it's going to be really, really tortuous, the Lima, you're going to get in some problems with pseudostenosis. And so I've seen patients totally crump with pseudostenosis from a Lima intervention. So I think that's important to consider as well.
That's a good point. So this is just a Corsair XS, and I couldn't even get this through. So workhorse wire went through the lesion, but this Corsair just got chewed up. I had to remove it and couldn't get it out. So
that's always a really, really bad sign. And I think for the CTO operators, that's one thing I learned from them is that if gear won't deliver, you're going to have to modify the plaque with either atherectomy or IVL. You know?
So this is kind of that algorithm that you mentioned. So wire across equipment won't deliver. So
and what are the rest of his arteries like, Arvin? Did you think about support with this person? Like, did they
thankfully his EF was okay. His EF was normal. He had a graft to the circ and a graft to the RCA. So he was protected from that standpoint. That's why I wasn't thinking of support, and his blood pressure was good. So here's the algorithm that we go through. Wire across equipment won't deliver. So options are more support. So I had a good amount of support, I thought, from the left distal transradial. Could go to a lower profile microcatheter, but you just knew that after it chewed up that there was a significant amount of calcium in there. And then, I mean, you could do the small balloon, maybe balloon-assisted microdissection by popping a small balloon, seeing if that modifies the proximal cap. The laser for us is on the 7th floor, and then the time it comes to take down that would be about a 15-20 minute process. So basically what we ended up doing is we got our microcatheter down as far as we could, and luckily the Rota wire was actually able to cross with our microcatheter nuzzled all the way in the plaque. So that's kind of the strategy that worked. So We ended up using
And
the
this is one I
1.5.
you know, I always worry, Arvin, with Rota and Limas is that the vibration. I guess you have the drive line, like that little cover that goes over the drive line, but I always worry about the rotation of the atherectomy will dissect the Lima. And I think that's what happened to Tierstein when he tried this case. But I guess if you start burring farther down like this, you might not get in trouble.
Exactly. And thankfully,
So you use a
I kind of
1.5
was
burr?
able. 1.5 burr, and like you mentioned before, there's not so much tortuosity that this was actually able to deliver cleanly through the graft. And then I only started essentially in the native LAD. So maybe we
Got
got
it.
lucky there, but it was super distal, and we were able to do probably three good runs of 20 seconds. I kind of
And
asked my.
what speed are you using, and what are you putting in your
I
Rota?
just did 160. If for some reason I'm struggling with that, I'll go to 180 and then 200 as needed. But 160 for me to start.
Got it.
And this did the trick.
My Rota goes 185, Arvin, because I'm the Joe Walsh song. My Maserati goes 185, so
That's
I
fair.
think
That's
it's
fair. So
comical
is
when I
that
do
so? Do
Rota.
you change your speed for size of burr?
I talked to Lombardi about this for a while, and he said that all that data on high speed rotation causing more no reflow is all kind of antiquated, and that with current dual antiplatelet therapy, that you're just going to be less likely to entrap the burr if you go faster. So I've gone to 185, and I haven't had any issues, and I think I've had more success crossing lesions, but I
Faster
don't know.
cross
That's
speed,
just
right?
anecdotal experience.
Yeah. And
So
this patient was loaded with Plavix before we knew we were going to do it. So Plavix on board, aspirin on board, and heparin on board.
got it.
So um, here we ended up actually using a Shockwave on top of it, just kind of doing the dual prep. I just feel like you get such a nice result with
I've had so much regret in like standalone Rota cases recently that I'm gonna just uniformly kind of dual prep these cases, I think. And I've heard, Chris Brown's got the LMR on the Arrow, the new Shockwave balloon that's more deliverable. He said it's pretty amazing in terms of how deliverable it is. So I'm looking forward to seeing how that, because I think, I still use Rota for delivery and Shockwave for expansion. And I think in most cases you need both. But it'll be nice for some cases where you can deliver the arrow just to kind of do standalone IVL,
yeah.
especially in a case like this.
This one was tough because I could barely get the rotor wire across, but
Yeah.
so you knew you
Yep.
needed something. But yeah, the 3.0. So and then Ivis was able to show fracture and everything like that. But at the end of this, I actually, because we were so distal, I didn't want to put metal there. I put a 2.5/30 drug coated balloon. Now I leave this up for about a minute. So we did good prep, good lesion prep, left this up for a minute, and then. Thankfully, after this, the patient had only chest discomfort but was not hemodynamically unstable. I gave weight-based heparin over 70 units per kg. I gave two boluses. I probably gave about 13,000 of heparin in this case. And then we ended up getting thrombus throughout the graft. So now I'm thinking, okay, is this no reflow
Yeah.
from the Rota? Is it
Is it dissected?
did I dissect something? And then IVIS, I pulled the IVIS through, and basically IVIS showed massive amounts of thrombus in the actual Lima graft. So then I
Huh.
checked my ACT, and two times I checked my ACT. Once after the initial bolus, it was subtherapeutic, just over 200, and then the second time, even after an additional bolus of heparin, again it was just above 200. So I mean that's when I got frustrated. I'm like, oh my god, should I switch to bivalve? I did think of that, but I've not been using bivalve. I can't remember the last time I did it unless someone has an allergy or something like that. But
Yeah.
I've not been
Hit,
using it routinely.
hit
So I,
patients. That's, I think, the only thing you use bivalve in these days.
right. So that's kind of my practice. But I saw this. So then I switched my mentality for how do I deal with thrombus then. So in the Pyxis, our Pyxis, all the nurses are able to get a good amount of lytics, and they're able to mix it up pretty quickly. So you don't need to call pharmacy. So they have lytics available in the Pyxis. So I just gave 6 milligrams of lytics initially, and
And
then
what did you give it through, Arvin?
just through the guide, because it
Got
just
it.
there's no branches or anything. So right through the guide. So
I love that.
6 milligrams of lytics, let it cook, then get the penumbra. Right at that time, wait about by the time everything comes, it'll be 5 minutes of lytics to kind of work and see what that works. I mean, the ways to deal with thrombus, right? It's either lytics, remove it with like a thrombectomy device, or push it to the side with stents. So
Yeah.
that's really the only ways
Just
to
try not to push it down. That's the biggest
exactly,
thing
yeah,
too, is like, don't push it
exactly,
down, keep it where it
exactly,
is, right?
exactly, right.
I guess you could throw a filter down and pull it back. That's the other thing some
That's
people
the
have
other
done.
thing, right?
Yeah.
Yeah, I guess it kind of goes with the remove
Yeah.
it strategy, right? So, yeah, thankfully he was stable. I didn't need support, but he did have chest pain. So you can see kind of the thrombus all throughout,
And
and
so
this
this
was
is after the DCB. You feel like you probably got a good result on the
yeah,
LAD itself, so now you have to deal with the actual graft. Okay.
correct. Now I'm like, now I need flow. I need to leave here with Timmy 3 flow. So, yeah, this was a nice technique. I like. I call it tattooing the clot, so you know where it is. So I did IVIS. You kind of mark it where it is, but it's always helpful on angiography to kind of see where the thrombus is. So I basically took a twin pass, proved that there was outflow. That was the number one thing. So I wasn't a no reflow issue because I did treat with verapamil and everything distally. But still, he had thrombus kind of in the graft itself. So I did put one stent up here in the proximal portion of the graft, and now I kind of was, I tried everything, and like you mentioned, I probably maybe pushed some clot distally, so I needed a stent to get Timmy 3 flow. So we ended up stenting IVIS
Oh,
based,
dude, that looks
and here
fantastic,
are the
Arvin.
results.
Wow.
So I guess the big thing is I'm curious if DCB is adequate or did I need to put a stent in? This is right after the result, right? So that's the question. Is DCB adequate for such a distal lesion, or
I
would
think
you
so,
put a
man.
stent?
I think these are the perfect cases because everyone's had kind of that nightmare experience with distal LAD lesions where you stent them and then you keep chasing your tail. And for some reason, Richard Schatz taught me this, that like the law of Laplace is that people get more angina in distal LAD lesions. It's very painful. Like they're screaming on the table.
Hmm.
And so I think DCB is a super elegant strategy. I mean, the proof will be in the pudding in 6 months if they come
Yeah.
back, but I think that looks fantastic. I think DCB is a great option for these cases.
I was thinking of doing a stress test on him, in 6 to 9 months, exactly
Yeah.
like you mentioned, just because I'd rather deal with it earlier than a total disaster of trying to do this procedure again.
No, I think that's
Mhm.
fantastic. I love the lytics too. There's actually going to be a trial at TCT about low dose lytics in lesions with heavy thrombus burden, and I
Yeah.
think if you can get them early, like I think if it's organized clot and it's a late
Mhm.
presenting, you're not going to get much result with lytics. But I think in a fresh thrombus like this, I think it's a super
Totally.
elegant
I,
approach,
I
and
I
I think
found the best way is what Hadi has taught us with you poke some holes in the balloon. They really need this device out there. You poke
yeah,
some holes in the balloon and give lytics through the balloon. There's some pharmacomechanical benefit to that.
Greg
Um,
Stone had a balloon that was a drug delivery balloon, but I don't think it ever got legs. I remember that when I was a fellow like 10
I
years
do
ago.
like this idea, and the best thing I think for me is knowing what's in your Pyxis, and the nurses should know about it,
Yeah,
because we have like 6, 8, 10 milligrams easily available. Because if you call pharmacy, it's a 20-minute process. They'll
yeah.
they'll come and mix it, and it'll be 20 minutes later. By that time, I mean, no one has the patience for that, especially with a sick patient on the table. So.
Have you found anecdotally? Because a lot of my partners and sometimes I will give 2B3As through the guide. Do you find that lytics probably works better for thrombus? I mean, it
I,
makes more
I
sense.
don't know. We don't have any data on it. I
Okay.
like it just because it's easier and convenient. But I don't think that's a wrong strategy too, because we've used that in the past as well, right? But then the problem is they go to the ICU, they have non-access site bleeding. I mean, when I'm giving a low dose lytic 6 to 10 milligrams, ACT doesn't change. Most of the cases are radial anyway, so it's way less likely for major bleed or anything like that. So.
This result is fantastic, man. So in hindsight, would you have done anything differently with
I
this
think just
case?
just been maybe more aggressive with the ACTs. That's the only thing I could have think. I
Yeah.
mean, I think maybe be a little more responsible with ACT before doing Rota. But I mean, we were doing everything per protocol and weight based. It just didn't do the trick. Sometimes I
Yeah.
find this modern heparin it just is not
Dude,
as
it's so variable. I have
consistent,
some
right?
days where I'm like right on spot, everything's like 250 and above, and
Yeah,
other days where I'm just it's all the pig intestines in China. Like if there's like a good pig versus a bad pig,
yeah,
I feel
right.
that's like the
Oh my
the
God.
difference. But
Yeah.
this is fantastic. So I think learning points from this case, number one,
Mhm.
if gear doesn't deliver, escalate. And Rota can be done safely in Lima grafts with careful care. Dual shock is dual prep is a great way to modify plaque and should almost be done empirically these days, I think. And then And then the other thing I think is some of those tricks you taught us on the clot management. Get TPA in your Pyxis. Low dose TPA works well. You can stain the clot with twin pass. And then the other thing I think, Arvin, for these LIMA interventions is really having a lot of careful care watching the tip of that guide catheter.
I was going to say that. That's
it's
why
always
I think
important to
be as efficient. Get all your steps ahead of time so you're doing the least amount of exchanges. Last thing you want to do is dissect the ostium, because I'm pretty paranoid about it. So I'll actually image me removing gear whenever I take stuff in and out.
Yeah, I think that's like take the table, go back up to the ostium of the guide and make sure the guide's not getting sucked in when you pull stuff back. Because I think that's where people get into trouble is they're working on a LIMA, they're thinking about the lesion that they're treating, and they lose sight of the ostium of the LIMA when it goes down.
And good fundamentals when you inject, right? Just to, make sure there's no dampening of pressure and all that. It's just because they can get really sick if things go the wrong way.
And that's why I think the left radial, anecdotally, I think there's a lower rate of messing with the LIMA from the left radial. I just feel like it's safer. The guide is in a more stable position on the back wall. So I think that's awesome, dude. This was a baller case, Arvin, and I think you managed it really well, bud.
Perfect. Time will tell if there's restenosis, but I'm curious to see if folks would do it like a 2.5 stent. That's kind of the size of the vessel. 2.53. Yeah. So I'm curious if others would do a stent versus a DCB. That's the biggest question I have.
Well, I think the biggest thing with the DCB is you did exactly what you should have done, which is you made sure the vessel was prepped adequately, right? I mean, I think that's the big thing is that I think we're going to see a lot of people using DCBs in lesions that they did not prep appropriately, and the patient will come back. But this was very well expanded.
I don't like putting 2.5 stents in.
Yeah.
If I'm putting a 2.5 stent in, I'm thinking about a DCB.
Yeah. No, I think that's smart. That's super smart. And so what do you use, a 3.0 DCB or a 2.5 DCB?
I use a 2.5/30 DCB.
Got it. And you're sizing 1-to-1 for all those? You're not oversizing like you do for Shockwave sometimes?
No, I'm going 1-to-1 because I don't want to dissect. I'm afraid to dissect. So But a 1 minute balloon inflation if they can tolerate it.
Okay. I love it. Arvin, baller case, bro. Have fun at the crypto clinic. You want to show your scrubs today? This is our theme of the day, the Arvin Narula Cryptogenic Stroke Clinic, crypto.
Rather than board exams, we spend $50 on scrubs to promote our new brand.
I love it. All right, brother. You have a great day, man. Thank you for this case. It was fantastic.
You, Joe. Thank you. Appreciate it.